Assalamualaikum doctors. In this video I am discussing how can we manage a Down syndrome patient. So a patient comes with Down syndrome feature. We know that or known case of Down syndrome. First what we do? I will assess the patient carefully. I'll take height and weight and plot them on a Down spatial chart and revise his previous notes and compare the chart with the previous year's chart. I will examine the patient carefully. General examination including the thyroid gland, cardiac examinations, abdominal examinations, MSK and neurological examination. I will involve my senior or my consultant if needed and include multidisciplinary team. I will run some test investigations and revise his previous investigations in the last visit. Thyroid stimulating hormone TSH, which is the gold standard for diagnosis and follow up of hypothyroidism, and T3 or free T3 triiodothyronine. Okay, T4 or free T4 thyroxine. Thyroid autoantibodies, thyroid peroxidase antibodies, antithyroglobulin. Imaging and ultrasound NAC with thyroid radioisotope study in nodules are there. So we understand that the gold standard is TSH, thyroid stimulating hormone. Now I am telling the interpretation thyroid stimulating hormone. If it is with high TSH, low T4, we tell that primary hypothyroidism. If high TSH with normal T4, that is subclinical hypothyroidism. If normal TSH but low T4, secondary hypothyroidism, pituitary or hypothalamus, and severe non-thyroidal illness. Okay. So there is some investigation we do. How can we diagnose the Down syndrome? Antenatally in first trimester, that is mother protein in plasma beta HCG, non-invasive prenatal testing, that is NIPT, baby ultrasound looking for increase the nuchal translucency. Second trimester, what we do? Triple test, that is beta HCG is high, low AFP and low estriol. Third trimester 14 to 20 weeks, that is quadruple test, triple plus high inhibin A. Then 10 weeks what we do? Fetal DNA in maternal blood. 11 to 14 weeks we do the CVS chorionic villus sampling, and 15 to 18 weeks amniocentesis. Postnatal what we do? Diagnosis by karyotyping, trisomy 21, PCR for rapid result, full blood count, blood film, thyroid function test and NBS. Imaging we do the echo, abdominal ultrasound, chest x-ray, overnight oxygen saturation. Other are ECG, vision and hearing assessment and growth monitoring. Okay. So prenatal, antenatal, postnatal we are doing mainly the karyotyping. Trisomy 21 is the postnatal. And antenatal I already tell. 9 month what we test? Audiology, because visual assessment to exclude the squint developmental progress. 12 month we do the thyroid function test, thyroid antibodies. 18 month development and growth, check the dental health, search for complications like celiac, obstetric sleep apnea, atlantoaxial subluxation, type 1 diabetes mellitus, autism and leukemia. Every 6 month teeth, that is periodontal disease or malocclusion. Every year full blood count plus film. 2 to 3 year vision and hearing, thyroid function test, sleep study for obstructive sleep apnea. At every visit, review the parental concern, developmental progress, plot measures on drawn growth charts, and search for hearing and vision problems. Down syndrome is a multidisciplinary team. We involve the endocrine, cardiac, chest, dietitian, early support services, ESS, SALT, that is speech and language therapist, occupational therapist, ophthalmologist, ENT, physiotherapist, ortho, social service, educational healthcare plan, genetic counseling and developmental assessment. Thyroxine for life after consultation of endocrinologist. Okay. So comorbidities in a case of Down syndrome. What are the complications in Down syndrome? First of all, endocrine in DS. These are hypothyroidism, hyperthyroidism, diabetes mellitus, short stature and obesity. Hematological problem in DS are leukemia. Cardiac problem are AVSD, VSD, ASD, pulmonary hypertension. Respiratory problem are obstetric sleep apnea, recurrent chest infection, mixed hearing loss, but most common is conductive hearing loss because of recurrent ear infection. Neuropsychiatric problems are hypotonia, global developmental delay, and autism. Ophthalmology problem are myopia, cataract, glaucoma, Brushfield spot, nystagmus, and strabismus. GIT problems are duodenal atresia, tracheoesophageal fistula, Hirschsprung's disease, annular pancreas, neonatal cholestasis, celiac disease, screen at 18 months. So what is the genetic inheritance of Down syndrome? Very important. It is non-disjunction 95%, translocation 4%, mosaic 1%. Again, non-disjunction 95%, translocation 4%, and mosaic 1%. And causes of obesity in Down syndrome are because of hypotonia, hypothyroidism, unhealthy diet, decrease the level of activity, and increase the leptin hormone. So this is how can we manage Down syndrome patient, how can we follow up. Thank you.